A newly published randomized clinical trial in Frontiers in Pediatrics examined whether combining 0.01% atropine with orthokeratology lenses can improve myopia control outcomes compared with orthokeratology alone. Led by Ying Wan and colleagues, the 2-year study evaluated both the efficacy and safety of this increasingly popular combination therapy approach. As clinicians continue searching for strategies to better manage fast progressors and higher risk patients, the findings add to the growing body of evidence exploring whether combining established treatments can produce additive benefits in slowing myopia progression and axial elongation. Andrew, what can you tell us about this article?
Yeah, I mean, none of us have time to read everything that comes across, and gets published. But this is one of those articles where I think if you just read the headline, if you just read the abstract, you're going to miss a lot. So, I mean, yes, we know combo therapy is safe. Yes, we know it's effective. But what I actually thought was really pretty interesting. I mean, we know that humans are adaptable. Humans that are the most successful species on Earth because we adapt. But this concept of adaptation kind of plays into this article. This, along with many other papers that have come out, show that the strongest myopia control effect is in that first 6 months, and then it kind of tapers off a little bit. Um, and then similarly, the strongest effect that we had here were in kids under 10. And so when we combine those two concepts, it raises a lot of questions. Right now, most doctors who prescribe atropine start the drops and then it's just on cruise control. And you say you're going to be on these drops for years. I think probably in the future we'll move away from that. I think we're going to be moving, away from the cruise control and towards a pulse therapy. Maybe we do atropine like a steroid dose pack now. We start with a high dose. We step that down over the course of 3 months, 6 months, who knows? Give them 6 months off of the drops and then start it all again at the top of the year. Um, between what we talked about last time, where we know now that definitively tapering atropine is beneficial, and now we know that using atropine is most effective right after you start it. Well, the natural thing would be to combine those two concepts, and that leads us in the opposite direction of putting on someone on atropine forever. Um, and
I
so,
actually thought the specific paper was different from what you had said about the 6 month having the most, usually where we see the treatment effect for atropine, the most kind of concentrated within the first 6 month. I think this paper was actually very surprising because the first 6 month, it was actually not beneficial. So it's not clinically significant or not statistically significant for their p value. And it also wasn't statistically significant at 12 months. So I remember writing it down because I was like, oh, this is interesting because the take on this paper was actually it takes 18 months to be clinically significant, or I guess statistically significant, sorry. And then it's strengthened at 24 months. So it was more of a cumulative treatment effect in this specific cohort in China. And I think that was very interesting. So it's not that, hey, if you're adding atropine to ortho-K, don't judge it at 6 months. You got to do it for at least 2 years. So I think it's just been different from some of those combo papers that we've seen and those findings coming out of those.
now I believe I'll have to double check this. So uh, don't take this for fact, but I believe that was in the 10 years old and plus group. I think the 8 to 10 group still did much better 6 months, 12 months. And it was just that the older kids, it took long enough to get a cumulative benefit that was statistically significant. But you actually bring up a great point that I missed talking about with Dr. Michaud from the very first. He made a good point that I had not spent a lot of time thinking about, and that is just the nature of time, like you just said. And, I think we get trapped into thinking this is an on-off switch where you start treatment and growth stops, and that's just not how it works. If you evaluate your treatment too quickly, you might miss something that's actually working and is not just fully kicked in yet, essentially. So I actually think that's a great point by you, Priscilla. That is something that I probably need to spend more time thinking about. Clinically, how do we want to approach that? Um, because yes, there's a problem with waiting too long, but there's probably a problem with assessing too quickly and deciding whether something's working too quickly. So yeah, I think that's a great point.
Absolutely. Yeah, I think so many doctors, they assess within the first, it's like, again, all of our sales reps usually funnel their questions to me or someone else on the team. And they're like, doctor tried this for a few months and then there is progression. Like, what do we do? The product's not working or the contact lens is not working. And I'm like, let's revisit, right? Compliance, lifestyle, all these other things that can impact. It's not just, hey, it's not like, diabetes, you take the pill and everything is good, right? We got to still manage the holistic picture, right? And I think that goes back to, some of those takeaways from the first article where we got to customize our approach, but think about it differently per patient. But, I think for this specific paper, I think is really interesting was that there was a lack of significance at 6 to 12 months, but when they did a subgroup analysis looking at the treatment effect, there was a significant treatment effect for those who were 8 to 10 years old at that 24-month mark. And for those that were 10 to 12, there was no significant difference, right? And then you also brought it with the lower levels of myopia, -1 to -3. There was a significant benefit at 24 months. For moderate myopia, a little less so, our -3 to our -6. So I think a lot of these findings, it's very easy for us to just, again, apply something, but we have to be a little bit, I think, as a profession, more critical sometimes when a paper comes out and then there's this headline, like, because again, we start shifting how we think and then we overcomplicate it. So I think there's definitely that importance, like you mentioned, of time, but also looking at kind of case by case, right? So like specifically for this paper, it's just like, well, there's a sweet spot for combo therapy, which I'm like, okay, that's important to know because I think combo therapy is definitely overused in our profession. And I think you have that patient in front of you. They're desperate, right? They're a -3, -4. And you're like, I'm going to throw the kitchen sink at it. So I'm just going to do everything. But then I think the challenge that arises out of that is that how do you then distinguish which one is effective and which one may not be? And I think this paper kind of helps call that out as well, is that, there may be a specific type of profile where atropine with ortho-K is effective for long-term progression. Whereas, when you have patients that are older with more moderate levels of myopia, maybe ortho-K has already done most of that heavy lifting. So why put that burden on the patient to add on an additional drop on top of that?
Yeah. Well said. There's so many things that caught my
Very well
ear from
said.
what both of you said. Um, Priscilla, I think you made a great point about like, the relevance essentially of combination therapy when monotherapy should be implemented. And I do have some questions I want to ask both of you as a panel, but like to kind of like piggyback on what you said, Priscilla, like, are we looking at a point where combination therapy is outside of the advanced specialists? Because that's kind of how I view it. Is like we're having problems. I brought this up before, but like we're having problems getting ODs to start doing myopia management, let alone combination therapy. And I feel like combination therapy in the future is going to be the domain of the specialist. Like, that's gonna be how they define themselves as the specialist. Is like, isn't it more important to just, stick with ortho-K or MiSight or glasses or whatever, and not necessarily worry about doing combination therapy? Like, is this just are we just kind of spinning our wheels with combination therapy for the vast majority of optometrists who wanna do myopia management?
Well, my hot take is I don't think this should just be a specialist thing. I think every doctor is capable of understanding when to utilize a pharmaceutical because atropine is not without side effects. I think in this
Mhm.
specific study, they were trying to highlight that it had an excellent safety profile, but I think it's already flawed to begin with because if your placebo group has to use artificial tears, and we know kids should not be using artificial tears to begin with. They should have had a third arm that was just ortho-K, right? Like, or just atropine. So you're actually comparing apples to apples here. But I think in this specific study, that wasn't the case. So I do think that again, primary care doctors should be capable of using combo. I think as a profession, we should hesitate to start with combo though. Like we really should be giving treatment time, like Andrew had said, to assess whether or not it's working because like I said, atropine is it's not without side effects, right? It's a muscarinic and, antagonist. You're going to have dry eyes related to this, right? Because atropine is going to inhibit the tear production coming out of the lacrimal glands. Yes, we're using super, super small dilute, like 0.01%, but ultimately that pathway is still muscarinic dependent, so it's like we're still like intervening somewhere with a pharmaceutical and we're having patients pay out of pocket for it because we do not have an FDA approved option. Everything is coming through compounding pharmacy. So again, there is an economic burden of someone having to pay for the drop. But on top of that, you have to think about some of those side effects, right? In this study, they used 0.01%, and they found that they're like, well, there was a slight decline in, tear breakup time in the group that was using atropine plus ortho-K, but not in the ortho-K group at the 24-month um, time period, but it wasn't statistically significant. But that brings back to the flawed thinking, right? Because your placebo group was still getting an artificial tear essentially, right? So your comparison is not at the baseline of someone who isn't wearing anything on their eye, right? Or not using any artificial tears. And so there's definitely a ceiling effect that we're going to see for some of those side effects. So I think that's where it's really important for us to look at or scrutinize some of these papers sometimes. Because again, like Andrew's saying, no one has the time to really dive in and read this. And I think that's where industry, sometimes we do spend a little bit more time reading some of this. So like lean on us for some of those, insights because, if this is our specialty and we go around educating across the country on some of these things, we are spending that extra time to really kind of dive in and really understand it because the average practitioner we know does not have that time. So we want to be that educational conduit to be able to help translate the science into clinical knowledge. And this is, a prime example of it, right? Where we're calling out there's little nuances in even this paper being the first one, but we there's still so much we don't know. And I think in the myopia space, the more you spend in it, the more you realize that there's still so much to learn.
Yeah, well said. Andrew, anything to add before we move on to the next topic?
And just that, every case should be individual. And, I think that, every kid's different. Sometimes combo is the right answer. Sometimes it's not. I do tend to agree that, well, I absolutely agree that starting with a combo is probably not the right move for almost everybody.
Right.
When we look to other clinical areas, I think certainly my view and the view of I think most people is, I would not start a new glaucoma patient on a combo medication because again, if you get them two medications and you get an effect, you don't know which one's working. Is it both? Is it one or the other? And now that patient is on that for potentially years or forever, and you can't even say with any confidence that it's doing something. And I do think that's a problem. So I'm not against combo therapy. I think it has a really useful place, and we'll only learn how to use it better and more effectively. But yeah, no, I'm with you 100%. Don't start with it unless you have a really unusual situation.
Yeah. I've watched, I've watched ECPs get befuddled around like monotherapy, like, oh, I've got a patient, I should do something about it. Should I do my site or ortho-K? Well, if my site's going to do it, do my site, like go for it. Well, what about ortho-K? Well, are you prepared to do ortho-K? Well, no, I mean, I have a topographer, but I really don't have any experience with it. And I haven't done any ortho-K cases and I'm really not ready for it. It's like, well, then do my site. Like if my site will do the job, get it done. So it's like, I love the idea of combination therapy. I want to explore it more and more. That's why I keep putting it in our episodes here because I think there is an element of it that is in the future, is in our future. But like, I feel like we got a bigger problem in front of us, which is like, educate, get doctors off the sideline, getting them use the monotherapy treatments that we already have. We don't necessarily need to start combination therapy. Uh, all right, Priscilla, anything else?
I was going to add another thing. I think
Go for
a
it.
lot of these atropine studies or a lot of these combo like studies, it's like it's great to see the treatment effect, right? At some point, it's going to be maybe clinically significant because we're publishing it. But I think oftentimes there's no rebound data at all, and I think that's where, for me as a clinician, I also hesitate. When I think about some of those cases where I'm like, well, I like knowing that we are not going to lose the savings that we got, right? So again, like we need to give ourselves that time to understand the treatment efficacy, whether or not it's waning over time, but also like, what does that rebound look like? And a lot of these studies are coming out of China, right? So you have
Mhm.
patients that if are not Chinese, we really don't know what's going on, right? Because there's some uncertainty around, the generalizability of, the findings from the paper or whatnot. So I think yeah. So I think that those are the things that, as I'm thinking about this paper, when I think about combination, is that we have overutilized, I think, atropine too, because at the end of the
Mm.
day, your patients who are using atropine need vision correction. And we have other treatment options that offers vision correction and myopia management. So why are we not leaning as heavily into that? And, I've talked to a lot of doctors, and sometimes they tell me it's because they feel more of a doctor because they're prescribing a drop that they need to go to a pharmacy for. And I'm like, that should not be
Mm.
what's, guiding your decision tree on which treatment option you should be picking. It really comes down to lifestyle and what does it look like for the patient, right? Because if you're starting them on just atropine, you're still going to need vision correction unless you're using it for pre-myopes. But I feel like that as a category is also something I think that's an observation that I've made, I guess, being in industry and talking to a lot of doctors.